made you become a doctor, Dr. Slesinski?
I wanted to be sole supervisor of my life. I didn't want somebody to tell me to report for work at such hours. I wanted to be independent. And I figured medical profession would be okay.
When do you think you made that decision to go into medicine?
Oh, I made that decision back in about 1943.
And you were in college then, or were you?
I was an instructor in biochemistry at the University of Vermont Medical School in Burlington. Matter of fact, I started studying for a PhD, but I had the opportunity to go to Texas, Southwestern Medical College, the University of Texas, to study medicine, as well as get a salary for teaching biochemistry. So I left Vermont in '43 and stayed in Dallas until '47. And that's when I took my MD degree in 1947, June.
At the University of Vermont, right?
No, Texas.
Texas.
Southwestern Medical College, University of Texas. And after I got my degree, I took an internship at Mary Immaculate Hospital, Jamaica, Long Island, New York. After 1 year internship, I came to Worcester for a 2-year residency in medicine. That would be from 1948 to 1950. And that's when I started to practice medicine, July 1st, 1950.
Okay, so what did you choose as your specialty in medicine?
My specialty was internal medicine. I decided to go into medicine because that was my interest. I didn't care for surgery or obstetrics or psychiatry.
So, before we move on, could you tell me how much it cost for you to go to medical school?
How much it costed?
Yeah.
Well, I'll tell you. It cost me, in my opinion, too much, because the government had 2 programs, an Army Specialized Training Program where the Army boys got their tuition and books, everything free. And the Navy had a specialized program also when they likewise got everything free. I had to work my way. So I can't give you an exact figure, but it was much less than nowadays, much less. The figures nowadays I couldn't afford.
Right. So do you think the costs back then for you influenced you in any way of how you practiced after you graduated?
Not really. No, not really. I decided to practice here in Worcester because I finished my residency here in Worcester.
Yeah.
And I got to know people here. Besides, my home is in Northampton, about an hour and a half drive away from here. I wanted to be close to my people, yet far enough so they wouldn't interfere with my life and I wouldn't interfere with theirs. And that's how I decided to practice here in Worcester.
How do you think that medical school students today are influenced by the costs of medical school after they graduate?
Most of them are going to be highly in debt. It's going to take them years to pay off indebtedness. Fortunately, there's scholarship money available, and many of the students, I don't know how many, but I understand from my communications with Southwestern Medical College that a considerable number of them are helped. They need help. As a matter of fact, I get solicitations, but I'm out of practice and I'm living on a fixed income, you know. Besides, they have oil wells in Texas. They can well afford to donate money.
So describe a typical day of practice when you first started here in Worcester.
Well, I started July 1st here in Worcester. Office space was very scarce, and a psychiatrist he's now deceased, agreed to let me come in and share his waiting room with him and have my separate place to examine patients. Those days, we were getting $3 for an office visit. A measly $3 compared to now. It was only $3 then. And you ask if I make house calls. Yes, I made many house calls. House calls, I'd get $4. But if I had to inject a mercurial or a diuretic or something or penicillin, it'd be $1 more. Instead of $4, it'd be $5. That's all I'd make. And I used to make many calls, not just during the day, but even after midnight, when many doctors preferred not to go.
How was your time divided between the office and the hospital?
Well, in the hospital, I used to go to the hospital in the morning to make my rounds in the morning to see my patients, as well as to see patients that are under care of the interns, those who were poor and couldn't afford care. You know, we called that, that was city hospital care. That's when city hospital was very valuable. For the care of the indigent, those who could not afford paying. Besides the hospital, we had what they called an outpatient department, where during an OPD, outpatient department, where we would see patients, like on Chandler Street. That building is still there.
Right.
We would see patients free. They would get their medicine free. And if they were diabetics, they needed insulin or syringes, they would get that free. That was the importance of a city hospital, to take care of the indigent. So the other question you ask here, was care adequate? Could everyone get care if they wanted it? It was accessible if they knew where to go.
Right, right.
It was accessible. And I think in that respect, Worcester is as good as any city that I know of.
Okay.
Now, in the morning, in the afternoon, I'd have office hours, except Wednesday and Sunday. I used to have them even Saturdays. And I used to have them in the evening, too. There would be not 2 to 4, there'd be 2 to whenever I got through. 2 to 5 or 6, and then in the evening, 7 to 9.
Then you'd be making time.
But later on, I quit the evening practice, just the afternoon practice.
Would you like to elaborate more on your rounds at the hospital, or are you done with those?
Well, at the rounds, I would first see my own patients, my private patients,
Yeah.
because I had to write the orders and okay the orders. But the interns and residents were, of course, there 24 hours a day, so they kind of had some supervisory capacity to overlook and care for our patients, so they would write orders too. But I would have to okay them or countersign them. See?
Mm-hmm. So how else would you communicate with your patients outside of the office and besides house calls and out of the hospital?
Well, you know, many of my patients would call me on the telephone, and I would give telephone advice, and I would agree to call pharmacies for prescriptions for them, you know.
Yeah.
Maybe not a good practice now, but this is the way it was then, to save them funds, you know. I did not have what you call a rich clientele. I had working class people, you know, and most of them could afford my $3 fee, but occasionally the office visit was gratis. Occasionally. They didn't have the money. I didn't send any collector out for them.
Yeah.
Never did.
And most of your patients, they came from around the Worcester area?
Most of them were here in Worcester. I'd occasionally maybe see one from Auburn or Shrewsbury or Millbury or Paxton, but mostly Worcester. And most of them actually from what is known as the island, Polish section there, Vernon Hill.
Yeah, okay.
Vernon Hill. Because the majority of my patients were Polish. I did have a few Jews and a few blacks. And I've had Swedes and I've had Finns, Italians, but mostly Polish. And
Did patients?
then you ask here, did patients choose their physician and how? Well, in those days, you know, we did not advertise. Our advertising was our work. If our patients were satisfied with how I treated them, the word would get around and others would come. We never advertised in the Telegram and Gazette like they do today. The dermatologists prescribe everything, advertise. The cosmetic surgeons advertise. And even doctors joining HMOs advertise now. We never did that in our day. It was unethical. We acquired a practice by being available. When a patient called and wanted a house call, we made the house call. And that's how we acquired patients too. They're willing, the doctor's willing to see the patient in a home. They don't mind for less illness to come to the office. And that's how the practice was built up.
So
Now,
what do you think it was like for your family to have a physician in the household?
oh, that's a good question. The first 5 years, I spent most of my time in the practice and not too much time at home. I would be here for mealtime and to sleep. And then during the night, I'd be going out. So when I went for military duty 2 weeks out of each year in the summer, they perhaps were glad to see me go, because then they were free and on their own. So I think they had mixed feelings, but once we started vacationing, after 5 years, my wife and I never went anywhere without taking our kids. And we had 5 of them. We used to go to Hampton Beach or the Cape, mostly. So I had no regrets in that respect, and I think they were satisfied because at least they had vacation time, you know, and the nice warm waters of the Cape. Hampton Beach was too cold.
Would you like to elaborate on your 2 weeks of military duty a little more? Did it have anything to do with medicine?
When I came to Worcester, there was a major who asked me to join the National Guard. So I think shortly after 1950, somewhere in there, I joined the Massachusetts Army National Guard. We drilled here at the Armory on Salisbury Street, right at the corner of Salisbury and Grove Street. We would drill once a week at night. Then once a month we might have a weekend drill, like Saturday, Sunday. And then we'd have 2 weeks of duty that they call summer camp. First 2 or 3 summer camps I had, it was called Camp Edwards there on the Cape. Now it's mostly Otis Airfield, but Camp Edwards is still there. And other than that, we went to Camp Drum, New York. It's now called Fort Drum. That's in above Watertown, New York, not far from the St. Lawrence River, which on the free weekend, we'd go to the St. Lawrence and ride a boat on the St. Lawrence. But after I got through with the National Guard, after 20 years, I then joined the 373rd General Hospital in Boston. And I stayed with them for a few years. And then I was transferred to the 333rd Medical Laboratory, also with the reserve. So I had 27 years of military work, for which they now give me a small pension.
Okay. And was that overall a positive experience for you?
Was it what?
Was that a positive experience for you overall?
A strain?
No, a positive experience.
A positive experience?
Yeah.
Yes, I liked it. I enjoyed working with these soldiers. You know, I was once asked a question by one of these military men, how come as a doctor you bother coming here? Well, I says, you know, you soldier boys, you need doctors and you need priests too. So they had clergy as well as doctors. I says, that's why I'm here. I enjoyed the work, really. Besides, I enjoyed summer camp. We'd go out on what they call bivouac, out in the woods for maybe half the time, close to a week. Bivouac, sleep in tents out in the woods. Fight the mosquitoes.
All right. I think we'll move on to the science and medicine now.
All right.
Could you tell me what were the most typical illnesses that you dealt with early in your practice?
The most typical illness?
Yeah.
Well, one would be hypertension. Another would be peptic ulcer diseases, upper respiratory infections, and quite a few anxiety tensions, psychosomatic cases, people with anxieties. But we did also treat pneumonias. That carried on throughout my practice. But you know, we didn't have much to treat hypertension with in those days. It was diet, bed rest for a few days, low sodium diet, and maybe a little sedation like phenobarbital. That's all we had then. But later on, it was a great breakthrough. We had much better drugs like diuretics, diuryl, hydrodiuryl, hydropress, and ACE inhibitors like lisinopril, Zestril. These were great breakthroughs in the treatment of hypertension. Early on, we had very little to treat it with. Of course, another important breakthrough in treatment would be the presence of discovery of antibiotics like penicillin, tetracycline, and all the others, very highly specialized antibiotics, and the sulfa drugs. Then we had something to treat pneumonia with. Prior to that, there was very little we had to treat it with. You either recovered or you died. So, you asked the question, what was the worst epidemic you recall? I don't recall the exact year, but it was in the cold season. I don't know, maybe December, January, February. We had a very serious flu epidemic, very serious. And I made call after call, house call. They were too sick to come to the office, running 103, 104, fever, something like that, aches and pains, you know. That'd be the worst epidemic that I can recall, the flu epidemic. Now, you ask the next question, what's my attitude towards smoking and cancer through my career?
Yeah.
Well, you know, I myself used to smoke cigarettes and a pipe, but I gave them up probably 50 years ago.
Right.
The whole business. I could see no use to smoking. You'd go out on a call at night, you got to smoke a cigarette. I decided I'd give it up. And it was at that time not known the connection between smoking and cancer of the lung. That became known later on in my career. That would be added incentive, and I discourage patients from smoking. And my attitude hasn't changed. I discourage people from smoking.
Have you seen attitudes around you change a great deal? Around you change a great deal towards smoking?
Yes, there are quite a few patients would listen to me and then they quit. Quite a few, absolutely. They would heed my advice, you know. But if they kept smoking, I didn't tell them, don't come to see me anymore. I think maybe some doctors would tell them, well, if you can't follow my advice, go elsewhere. I didn't bother. I maybe felt like telling them that, but I didn't. Now, you know, technology, what is something doctors seem to take for granted now that I didn't have at some point in my career? Well, I can tell you right off, we did not have CAT scans. We did not have ultrasound. We did not have MRIs. All that was available to us when I began was radiology and electrocardiography. That's about all we had available. Nothing else. Now they have even echocardiograms, you know. They have angiograms, cardiac angiograms, cardiac bypass surgery, the whole bit. We didn't have that then. And as for what important invention you have seen, I would say one of the most important would be the ultrasound and MRIs, CAT scan.
Yeah.
These three grouped together. CAT scan, ultrasound, and MRIs. Very important now in the practice of medicine. Nowadays, unfortunately, some physicians don't bother to do a history and a good physical.
Yeah.
You should listen to the patient to find out what's wrong. A good history. Now they go to the laboratory studies and these technical studies, and then they practice from there. You have a headache, you get an MRI of the brain or something, you know, instead of going into a history, whether it's a migraine headache or what it is, or an anxiety headache. But that's the way it is. Well, of course, I stopped practice about 10 years ago, and some of this was just coming in then. The MRIs weren't in yet, I don't think. The CAT scan was in 10 years, or over 10 years ago. That was available to me. Ultrasound came a little later. Medicine has become more technical. It's not as personal as it used to be. Not as personal. And I think that's wrong. I think you should know your patient and your patient should know you and trust you.
So do you think in general that doctor-patient relationships have deteriorated over the years?
In some respects, yes. Nowadays, especially with the HMOs here, you know, there isn't that personal relationship, the one-to-one relationship, one doctor, one patient. You go to an HMO and you don't know what doctor you're even going to have. They have several doctors. It's a group practice. Well, there's some advantages to a group practice too. You know, they have a specialist in GI workup, a specialist in genitourinary stuff, and cardiopulmonary specialist. So you can be steered to the right physician in a group practice like an HMO. But the bad thing of HMOs, it makes us poor solo practitioners because our patients go to the HMOs and leave us. And I've lost many patients that was over 10 years ago, because of the HMOs. They would migrate. HMOs would maybe charge $3. You know, by then my fees were higher. You know, everyone's fees had to be higher. Office expenses were higher. You know.
When exactly did the HMOs start affecting your practice?
The side effect?
No, when did they start affecting your practice?
Oh, this got to be before 10 years ago, because I quit 10 years ago.
Okay.
So it'd be longer than 10 years ago. That's one reason I quit. My practice was dwindling. My office expense was remaining higher and higher. Each year went up. Downtown, I had an office on Main Street. And actually, maybe they did me a favor. Get me out of practice. Now I can spend more time with my wife and family.
What is some other technology that you used maybe early on in your career or in medical school that's still used today?
Well, when I was in medical school, the only technology we had, I say, was the radiology. X-rays, chest X-rays, GI series, Graham Cole series for the gallbladder, colon, either the colonoscopy or X-ray of the colon, barium enema, you know, and the cardiograms. That's all we had then. It was adequate, though, if you take a good history and have a good personal relationship with your patient. A good history and a good physical. And then you could prescribe. Fortunately, as my practice matured, more drugs became available. More drugs became available so we could treat better. And actually, the one question you asked, how did changes in drugs and drug industry affect your practice? Well, I would say favorably. You could treat patients better and get them well faster. So in that respect, the drug industry has been quite helpful. And as a matter of fact, you know, the drug people would send representatives to us to introduce new drugs and give us information. And I found that very helpful. I never refused to see a representative of any drug house. An occasional doctor wouldn't see him, but I saw everyone who knocked on my door.
But they don't do that anymore, right?
I doubt it. I doubt it. Of course, I've been out of practice 10 years, so far as I know, but I doubt it. I doubt it. They used to also conduct seminars, you know, where they would pay us a fee and have an evening meal with it. But they stopped that too. But I found that enjoyable because you meet with your colleagues and you discuss ideas with your colleagues. That was, in a way, okay. That was one good thing about the drug industry.
What were some of the drugs that you used in your practice? What were some of the drugs that you used in your practice, and how did those change?
Well, you take for hypertension. I started with the diuretics. Diuryl, hydrodiuryl, hydropress, and more recently, the ACE inhibitors, like lisinopril, Zestril, which I find are very, very helpful. You know, the old low-sodium diet, bed rest, and phenobarbital, that's gone. Now we can get a patient up and around, back to work, and a useful life much sooner. And as far as the other drugs, you know, the penicillin, ampicillin, the tetracyclines, very valuable. And as far as the GI problems, you take Tagamet, cimetidine, or Zantac, ranitidine, for peptic ulcer disease. We didn't have that before. All we had then was soda bicarb or Maalox, you know, the antacids, and watch your diet. Nothing fatty, fried, or greasy. Nothing sharp. That's all we had. But now with ranitidine, the Zantac or Tagamet, the cimetidine. Very useful in peptic ulcer disease. And of course, for irritable bowel syndrome, the colon, the diarrheas, we have drugs like Librax, combination of Librium and clinidinium, Librax, tranquilizer, and antispasmodic. So these are drugs that I've used and found very helpful.
Do you want to move on to access to care now? The next one?
Access to care, that's okay.
I think we've already covered the first part. But could you tell me what were some fears and concerns about socialized medicine in the 50s and 60s?
Well, yes. I didn't have any fear. When I could see so many indigent in need of care for the poor, I was not against socialized medicine. As a matter of fact, I would have welcomed it, because then everybody would have access to care. Everybody. Socialized medicine, nobody is left out. My attitude hadn't changed. It still hasn't changed. I wouldn't care if we had socialized medicine. As a matter of fact, going further down here, even though I never became politically involved in this subject, but I feel very strongly in favor of Medicare and Medicaid. This was an excellent advance in health care. An excellent advance in health care, Medicare and Medicaid. And I would hope that this program would continue, because I'm still in favor of it. I'm in favor of it. Granted, those who have a little money may have to contribute a little bit. But those who don't have it don't contribute. They get on Medicaid. And Medicaid picks up what Medicare doesn't. So everybody can be treated. I'm very strongly in favor of it. Now, you know, do I think government has become more or less involved in health care? I would have to say more. The Medicare and Medicaid is okay. But now we have limited hospital stays. We have what they call managed care. You're in the hospital 1-2 days and out. I don't approve of that. There's some cases that should be in the hospital longer and under closer supervision. But that is one thing that I would call government interference. And you know, when in a nursing home there's a small incident, like some patient hits somebody or somebody falls, nobody gets hurt, the state here in Massachusetts mandates that incident must be reported then and there to the physician. They call you late at night to tell you this. Patient fell but didn't get hurt. So can't the call wait till morning? You gotta wake me up and tell me that? That's one bad thing about government interference. And I think in some cases they can tell you what you can prescribe to and what you can't. I think, as I recall, I had that experience. Well, I don't know. I think we've answered most of the questions.
Do you have your own perspective of how the government should...
Do I have what?
Do you have your own perspective of how the government should be involved in healthcare? What should happen?
I would say this. Continue Medicare and Medicaid as it is. And I would also say, don't change the Social Security, because that's involved in this too. What Social Security some of these patients get helps to pay for their nursing home care. I guess you know that. So I think in that respect, everything should be left alone. Avoid further government interference. They may be well-intentioned, but I think maybe they're telling the medical profession too much. Too much.
Overall, how have you seen the government affect the public's access to health care?
Well, if they leave everything the way it is, everyone should have access to health care. Everyone. The only thing is, I understand, like St. Vincent Hospital, the poor and indigent who can't pay, they get free care still. This is what I'm told. I know at City Hospital, that was so. The expense was taken up by the city. And at St. Vincent, I don't know how it is now at that medical center, but I know when they used to be here at Vernon Hills, the old St. Vincent Hospital, the poor who didn't have anything to pay, there was a certain percentage that the hospital granted free care. And I know they had free clinics there too. Probably not as many as they did at City Hospital, but I know they had free clinics there too. So in my experience, I'd say nobody should be without health care in this country. And nobody should be starving in this country either.
Especially in this country, right? Yeah.
Oh.
Okay, well, let's move on now. Could you tell me how doctors' salaries have changed over the course of your practice?
Well, with third-party payers and code numbers, the doctor submits a code for his work, and he is paid by the government according to the code. And they are now very well remunerated. Up to $50-some-odd for an office visit, for example. Something like that. $53, I don't know. Can't tell you for sure now what it is. But they are very well paid compared to what we were then. They're very well compensated.
Where did most of your income come from in the early part of your career? Was it just the office visits and house calls?
When I first started, yes.
Okay.
That's where it mostly came from. But later on in practice, I used to go to practically every nursing home in this city. Clark Manor, Bancroft House, Hammond House, Spring Valley. Practically every nursing home I used to go to. And those calls would be paid through the government one way or another. Medicare and Medicaid. So at first my practice, my income was due largely to the office and my house calls. But later on, it changed. Less from my office and more from Medicare and Medicaid. Which was much less then in my day than it is now, but it was adequate. We weren't starving. You know, when I first started practice here in Worcester, one of my physician colleagues, who is now deceased, he says, "Frank, if you start practicing in Worcester, your children will starve." Oh. He wanted me to go up there near the New Hampshire border. I forget the name of the town. Well, you know, I'm specializing in medicine, internal medicine. Yeah. I want to stay in a big place, big city like Worcester. Yeah. I don't want to go to some little farming country there, be a general practitioner.
How has malpractice insurance changed over the years, as well as its impact on doctors' practices?
Well, I'll tell you. An internist didn't pay anywhere near as much as the orthopedic people or the OBGYNs. They're the highest. The psychiatrists were, I think, the least, and we were somewhere in the middle. I had started at a pretty good fee. It's one more reason I decided to close my office. The fees, malpractice. But when I closed the office, like 10 years ago, I continued to go to these nursing homes. But I let my insurers know that my practice is now limited to nursing home care. They dropped my malpractice, I'd say close to in half. They dropped it. Well, I still had to carry it, you know. I carried it until June of last year when I quit everything, and I dropped everything. So, actually, you had to make an awful lot of nursing home calls to meet just your malpractice. It wasn't paid. I was working for the government. One reason I quit.
How did you learn the business of medicine?
How do what?
How did you learn the business of medicine?
How did I learn the business of medicine?
Right.
Well, you know, it didn't used to be a business.
Right, yeah.
It didn't used to be a business. It was a personal thing. My patients mostly would pay on the spot. Office visit, they'd pay me those $3. House call, they'd pay me those $4, you know, in those days. They'd pay on the spot. They didn't have to do much billing, you know. Matter of fact, I didn't have a nurse in the office to help me with this. My wife is a registered nurse, and if any billing was to be done, she would do it. But that's as far as the business went. And I don't think I overcharged. As a matter of fact, I think I charged as little as any physician here in this city. And I have no regrets about it because, contrary to what this doctor says, my children did not starve.
Do you think that medical economics is a subject that could be covered more in medical school, or should that be left alone?
You know, there are other things that could be covered more in medical school besides just economics. They didn't teach us anything about the business of practice of medicine. They didn't teach us anything about abortion, pro-choice, that. They didn't teach us any of that. The only thing I knew when I was in medical school, I think in my sophomore year, taking pathology, there was this one lady on the autopsy table who would try to perform an abortion on herself. But other than that, I didn't learn much about interfering. Didn't need Dr. Kevorkian, you know, to help assisted death get out of this life. But you know, I went to a talk at, I think it was at Memorial Hospital some years ago, and there was one proponent and one opponent to abortion or to interfering with life. And the one who was in favor, it says, his father suffered so much from a cancer that was incurable that he would be entirely in favor of it. He would summon Dr. Kevorkian, I think. The other party said no. Morally, it's wrong. The church, you know, is against it.
Yeah.
Catholic Church in particular. I don't know about the other denominations, but I know the Catholic Church, to which I belong, is against interfering with life. Morally wrong. But I think the medical school should perhaps get a little more involved with the business end, especially nowadays. You know, used to be just a profession instead of a business. You know, a profession.
Yeah.
Well, now it's become almost like the lawyers. The lawyers is strictly a business. You consult a lawyer, you get a bill in the mail right away, and not an inexpensive one. They know how to charge. They're more into the business. But the medical profession is not so much a profession anymore. It's become a little more of a business.
Yeah. Okay. We'll move on to the Worcester community now. We'll talk about the Worcester community now. Next page.
Which page?
Worcester.
I don't have another page.
All right. Well, could you tell me what some changes are that you've seen in the demographics of Worcester?
Well, the only thing that I see more of is that many, many more Puerto Ricans and quite a few more blacks. As far as other immigrants, like the Russians, the Poles, Italians, Finns, we haven't had that many. Some, yes, because they come to this country because life isn't as good in Europe.
Right.
They come here for a better life, for a good job, 2 jobs by one person. That's why they come. But I think the biggest change in the population is much more Puerto Ricans and quite a few more blacks. They're all gonna, oh yeah, I didn't have this.
Okay. So did the ethnic background of your patients change a great deal over the years?
Not really. Like I said in the beginning, my practice was mostly with the Polish people, but I did have other ethnic groups. I had Italians, Finns, Swedes, Russians, few Jews, and a few blacks. I don't think I ever had a Puerto Rican. Not one. Of course, that was over 10 years ago.
Okay.
How did women's health in Worcester change over the course of your practice? Well, the main thing I've noticed is that we have much more female physicians now. Many more female physicians. It's getting so, you go to a meeting and they outnumber the men. They do.
Yeah.
I have no objection to that, especially, but they're not going to make the house calls that I did. They're not going to go in the middle of the morning, 2, 3 o'clock in the morning, climbing up these 3-deckers. There are a lot of 3-deckers in Worcester. 3 stories. Climb up in the middle of the night, and you don't know when somebody's going to club you. Fortunately, I was never harmed. But women's health, one thing, an ordinary delivery, you're in a hospital and you're out the same day, obstetrics. But with a cesarean, I think they allow them to stay maybe up to 3 days, which maybe isn't enough. But that has changed. And in that respect, the women's health isn't given the care they should be given. But in the course of my practice, you know, I had women in my practice, hypertensives, plenty of psychosomatic cases, anxieties. They were concerned. If they had symptoms, they would come to you sooner than the males. At least that's the way I found it. Now, have there been changes in how children are cared for? You know, I was not a pediatrician. I would see some children, you know, from age 12 on, or that I could handle, but the older age group. So as far as I know, the children still get pretty good care. But like I say, not being a pediatrician, I can't give much more information on that subject. Well, how has Worcester been different from other places you've practiced? Well, I've only practiced here in Worcester.
Okay.
I've never been anyplace else. Once I started, July 1st, 1950, I stayed here until June 10th, 1951, last year.
What are some things that you like and don't like about practicing here in Worcester?
Beg your pardon?
What are some things that you like and don't like about practicing here in Worcester?
Oh, well, the main thing that I haven't liked about practicing in Worcester, in the daytime especially, is the traffic.
Okay.
The traffic has always been a problem. When I made the night calls, it was easy. Nobody on the road. The night calls were easy. But the other thing is, the people here have been kind to me in Worcester. I probably never sent away anybody from my practice more than one patient, and maybe only one or two ever left me, to my knowledge. We hit it off pretty well, but nobody is 100% perfect. Nobody is infallible. They say not even the Pope. Everybody is not infallible. We all can make a mistake. But I think the people in Worcester have treated me very well. Matter of fact, when I was a resident at Worcester City Hospital, I think I got along very well with the staff and with the nurses. And you know, you can't run a hospital without the nurses. Yeah. It's nice to not to have a nurse as an enemy. Have a nurse on your side and your battle is half won. Yeah. What advice do you have for younger doctors?
Well, actually, I'd just like to save that question for later.
All right.
Could you tell me how public perceptions of doctors have changed over the years?
How what?
How the public perception of doctors has changed?
Oh. Well, I tell you, I think they have less respect now for doctors than they used to. The public in general. There was an article in the Telegram and Gazette within this past week that all doctors are not good guys. In the Telegram and Gazette this week. Some of them perhaps are a little rude. Maybe that's the word. It's quoted in this article in the Telegram and Gazette that this intern or resident walked into a nursing station and he yelled to the nurses, "Don't you know enough to stand up when a doctor comes here?" And the nurse supervisor says, "Well, I don't think you're ever going to be a good doctor. No one's going to stand up for you." That's in the Telegram and Gazette.
Wow.
For the public to read. Well, in my own experience, I think all my patients have treated with great respect. I have no complaints. And that's 10 years ago now. Those in the nursing home, you know, that I've seen, they're too old to complain. They're old, they're senile, or they got Alzheimer's, or, you know, incapacitating illnesses. strokes, then they can't complain anyway.
How do you feel the role of the physician in this community has changed over your practice?
Well, you know, I think now the physicians do not make house calls. They get called on the phone for someone who's sick, and they say, go to the emergency ward. This is the big change. I don't approve of it exactly unless I go also to the emergency ward and see them there myself. But this is one big change that I don't approve of. In that respect, the doctors aren't as respectful to their patients as they should be. If you have a patient and you get a call, you should see them, not refer them. Unless, of course, you get a call from a patient with a very serious nosebleed or something, you know. Well, I'm not specialized in ear, nose, and throat. I would be entitled to refer to the emergency ward and let them call an ear, nose, and throat man. You know, I would do that where I feel incompetent. It's not my field. See?
Was there physicians that you admired when you started practicing here?
That I admired?
Yeah.
Yes. And a couple of them are now deceased.
Okay.
I admired very much Dr. McDonald, Dr. John D. They were two of my first staff physicians at City Hospital. They were gentlemen, true gentlemen. And they used good language. Nowadays, I don't know what these younger ones talk, but I've even heard some of these female physicians use profanity.
Wow.
I have, not often.
How did group practices or hospitals treat minority physicians early on in your career in medicine?
Well, you know, at City Hospital, that's where I did most of my hospital work before they closed it. Then I had to go to St. V's or Hahnemann or Memorial. But from my point of view, the blacks or other minorities were not mistreated. They were treated the same as anybody else, particularly a City Hospital, which I know. And I will say this, when I was still in medical school, wearing whites in Texas, Dallas, Texas, where there are a lot of blacks, the blacks showed us great respect, more so than some of the white patients. The blacks respected us. That's when I was still in medical school. And actually, like I said originally, I've only had one or two blacks in my practice. But they weren't mistreated. They were treated the same as anybody else. And I don't think I had one Puerto Rican, not to my knowledge, that I can remember. Not one. Well, other minorities, you know, you could call a Pole a minority. Polish fellows a minority. We're minorities. Lithuanians, some Italians. You go to Shrewsbury Street, you're not a minority. They're all Italians. Shrewsbury Street. See? But they can be classified as a minority. Actually, I think in this city, especially in the police department and the fire department, the Irish predominate. A lot of Irish. But they're treated the same as anybody else. They're not a minority. I'd say they're a majority.
With medicine being such a changing field, how have you seen yourself keeping up with the changes in education after medical school and throughout the course of your career, even to when you stopped?
Well, you know, being in retirement, I'm not nearly as much concerned with it. I do read medical stuff, and I have gone to rounds, you know, to listen to case studies like at St. V's. I've done that. I haven't in the past year. Past year I've done very little. But I feel that medical rounds at once, it used to be at St. V's once a week, where a case is considered from every point of view, where you have a radiologist, you have a GI specialist, a cardiologist. The patient is considered from every point of view. I think that's important. I think seminars are also important, where a seminar is presented like at a hospital. That's important too. You don't have time to go back to medical school. Your time is limited if you're in practice. But you can choose your interests. And those seminars that may be of interest, you should go to. If they have one on GI disease that you're interested in, peptic ulcer, irritable bowel syndrome, something like that, you should go. But if there's one on cesarean sections or something like that, it's out of your field, you're not interested, you don't go to.
Right. Well, Dr. Slesinski, running short on time, could you just quickly tell me what advice you have for younger doctors to wrap up this interview?
Well, the younger doctor, I would say first of all, when you start practicing medicine, learn to listen to the patient. This is of great importance. Learn to listen to the patient. They will tell you what's wrong with them. And then do a very good physical examination. And then appropriate studies. If you think some laboratory study is necessary, or x-ray or cardiogram, order it. If they're not necessary, don't order them.
Thank you very much, Dr. Slesinski.
Well,